Sorry, so we have a little bit of a change in schedule. Dr. Kobitary is here to talk about the pulmonary aspects of neuroendocrine, but he's also covering the intensive care unit at our hospital, so I need to get him out of here. So if it's okay with everyone, we'll have to change a little bit. We'll put the Q&A session and we'll probably move it down just into the afternoon, and then we'll bring him up now and have him talk. So if you still have any questions, keep filling out the cards and put them over there, and we'll do them all the QA session. Is that okay? All right. So anyway, I have the pleasure of presenting Dr. Majd Kobitary. He is the first pulmonologist I met here in Denver, and he's been really great. And he's going to talk to you about kind of what are some of the maneuvers for improving pulmonary function, what are the pulmonary function tests, and what are bronchoscopies, and how helpful it is. So, Dr. Kobitary. Come.
Thank you very much for inviting me here. It's a very pleasure to talk about the pulmonary aspects of pulmonary carcinoid. Of course, pulmonologists, most of us think that we own carcinoid, but we actually don't, because most of the time we make the diagnosis and we don't see those patients for a while. I want to talk about, in general, about the role of pulmonologists in neuroendocrine tumors, and it's mainly the typical carcinoids. Those patients usually present with respiratory symptoms. So we tend to be the first doctors to evaluate those patients. And in the past, 10, 20 years ago, we used to think of all those as very benign tumors or etiologies. Then our oncology colleagues started telling us that no, this is very malignant. And at some point we started thinking it's probably somewhere in the middle. So what we tell our patients most of the time when we diagnose them with pulmonary carcinoid, it's like cancer in slow motion, but it can change behavior at any point. So that's what we usually tend to, that's how we usually address those patients. We tend to see a lot of patients with lung cancer. For every probably 50 patients with lung cancer, we see one patient with pulmonary carcinoid. So relatively, it is benign, but it is not completely benign. The other role for the pulmonologist is to do the bronchoscopy. So the bronchoscopy is the procedure where we advance the tube with a camera into the airways, and I'm sorry, I've walked fast here, so I just need to take a deep breath here. Yeah, exactly. I'm thinking about a good one around here. So a bronchoscopy where we advance a scope that has a camera and a light in the airways, and we evaluate the inside of the airways. Luckily, most of the carcinoids are inside the airways, so doing a biopsy for carcinoid is usually would give us a high yield, as opposed to lesions which are very far in the peripheries of the lungs. The yield of bronchoscopy is not very great. Also, the pulmonologist would have a role in evaluating the pulmonary function test. Those are very important if we are contemplating doing big resection, especially in pneumonectomy, where we're thinking about removing the whole lung. Then a pulmonologist would have a role in making sure, thank you very much, appreciate it, to make sure that the patient would tolerate having a resection of the whole lung, and that they would not be very dependent on oxygen or respiratory support if we end up doing that. And also, I'd like to talk about that last section, the endoscopic interventions. Probably for most of us, it would be a new subject. But there has been a lot of advances recently about the role of endoscopic treatment of carcinoma. Typically, it's surgical resection. For some selected cases, we believe that endoscopic intervention has a role. And this is just about the history of carcinoid. So you can see that at the beginning, almost all of us thought this is a completely benign tumor. And it wasn't until 1972 till we realized that there is a spectrum of disease that starts from typical carcinoid, which is the very benign, and it ends up it ends at small cell carcinoma, which is a very aggressive tumor. So for the definition of bronchial carcinoid, most of the time we think of it, excuse me, we used to call them bronchial carcinoid because most of the time they are in the bronchus, they are in the large airways, but sometimes they are in the periphery of the lungs. And that's the reason I think the proper term would be bronchopulmonary neuroendocrine tumors. And this is just the WHO criteria for the diagnosis. So we have on top the typical carcinoid, which behaves, and Maggie was probably talking about that, which behaves in a very non-aggressive way. Atypical carcinoid is more aggressive, and it's a spectrum of disease. This large endocrine carcinoma and small cell carcinoma, this is more of a actual lung cancer as opposed to neuroendocrine tumor, but I'm not the expert in that field. And so to me, when I talk about pulmonary carcinoid, I'm talking about those two, and those I would say would belong more to the non-small and small lung cancer. So pulmonary carcinoid or bronchopulmonary neuroendocrine tumor arises from the airways. And it could be large airway, we call it bronchus. It could be small airway, we call it bronchiole. And that would, and based on where the location of the origin is, that would decide whether this would be more in the central airways or in the distal airways. This is a not very common disease, but it's also not extremely rare. It's only about 1 or 2% of lung malignancy. So as I mentioned, for every 50 lung cancer we see only one carcinoid. But it's also the most common lung tumor in children and young adults. So it's not very uncommon. But the good thing is for carcinoid, it's also the typical carcinoid is way more common than the atypical carcinoid. So for most carcinoid that we see, typically they are not as aggressive. And recently we have noticed that we are seeing more carcinoid than usual, or than average. And there is some theories about that the incidence of the carcinoid is increasing, but also probably it's more because of the better recognition of this disease, and probably because we use CAT scans more liberally right now for lung cancer screening or for evaluation of respiratory symptoms. So we have a very low threshold to obtain scans of the chest, which would usually give us the diagnosis. So probably it's a combination of both. And just that, oh, sorry. Oh. I'm staying here for now. There are some differences in the incidence between men between males and females, and between African Americans and Caucasians. White females have the highest incidence, and that would be 0.89 per 100,000. It's still a rare disease, but we tend to see a lot of this. We tend to see this carcinoid syndrome probably about carcinoid tumor about 3 or 4 times a month. So it's not very uncommon. Smoking. So smoking is very well linked to regular lung cancer. For carcinoid, there has been some reports that there is some increased incidence of smoking, that smoking might be contributing to lung carcinoid, but at this point, there's no relationship, there's no causal relationship between smoking and carcinoid. And that means at this point, it's not a preventable disease, and that would explain why it develops in children and young adults who would not have had a chance to have extensive history of smoking. But there is also some evidence that atypical carcinoid might be associated more with smoking. And also there is no, most cases of bronchial neuroendocrine tumors are sporadic, and there are no specific genetic predisposition. So The presentation of bronchial carcinoid all depends on location. So for carcinoids that are in the peripheries of the lungs, they grow very slowly and usually they are completely asymptomatic. And you can see from here that if the carcinoid wants to make their area here, that would cause complete collapse of the lungs. That would be very symptomatic. If the carcinoid develops here, then it will have to grow a lot before it causes. So most of the peripheral carcinoid are asymptomatic. Most of the very central are very symptomatic early on. Luckily, carcinoids rarely ever arise in the trachea, but they can. Oh, I'm sorry. So they rarely ever arise in the trachea. I actually saw a report of 0.7% arise in the trachea. So it is possible, but it is not very common. The more common are the major airways. So 75%, so 3 out of 4 of carcinoids would be accessible in the proximal airways and would be able to see it on bronchoscopy. So because the cough receptors are in the airways, once you have carcinoid that develops inside the airways, patients can have cough. Dyspnea is related to the limitation or narrowing in the airflow. Those tumors are very vascular, so hemoptysis, coughing up blood, is not uncommon. Atelectasis is the complete collapse of a lobe or a lung. And because once you have a blocking tumor inside the airways, secretions would have difficulty clearing from inside the lungs, so patients would be susceptible to infections or pneumonia. And that's what I want to show you this slide about how the blockage or narrowing of the airway results in dyspnea. So when we have wide airways like here, the flow becomes the flow is laminar and efficient. When you have narrowing of the airway, because of the changes in the pressure, the flow becomes turbulent. And you see with the turbulent flow, that's very inefficient way. So that's the reason patients have to create a lot of pressure to have the same amount of air inside their lungs, and that's why patients with carcinoid, bronchial carcinoid, especially if it's blocking the central airways, would have dyspnea. And this cartoon just explains why we have atelectasis from bronchial obstruction. The airways are the conduit to deliver air into the lungs. So if you have complete obstruction in here, then there would be no air that would go into the lungs, and then the lung would collapse completely. If the blockage causes a one-way valve, that would cause the air to go in and would not be able to come out, and that would cause hyperinflation, and that would cause wheezing, and also would cause dyspnea because the lung is very inflated. Can I do that? So 75% of the bronchial tumors are central, 25% are peripheral. When they are peripheral, they rarely cause symptoms. And now we're detecting more peripheral carcinoids, and that's because we do more CAT scans, as I alluded earlier. And the lung cancer screening program, which we started doing more lung cancer screening in the last 2 years, we started seeing more peripheral lesions, and we started diagnosing more peripheral carcinoids. So probably this number would change eventually, would not stay at 25%. It would probably go up and would start detecting more asymptomatic pulmonary carcinoids. So I want to mention something. We know that pulmonary carcinoid is rare, and we were trained, most medical students are trained not to think of zebras when we are dealing with a new medical problem. So if a patient walks into our office having shortness of breath and wheezing, we don't think of pulmonary carcinoid, we think of horses like asthma. We think of something that's common, and that's part of the delay, part of the reason that the diagnosis is delayed. And we need to have a high level of suspicion before we get to the diagnosis. So this is a patient that we saw for 2 years. She was having shortness of breath and wheezing and cough, and she was treated for asthma for 2 years. Her spirometry was borderline, and it was until we did a CAT scan and then a bronchoscopy, then we saw that she has a bronchial tumor, and it was carcinoid. So differential diagnosis is wide, but we tend to see those patients early on, and most of those patients would go through several courses of antibiotics, bronchodilators, before eventually the diagnosis is made. Bronchial carcinoids, and Eric probably would know more about that, but pulmonologists think of them as non-syndromic, as that they do not produce serotonin. And most of the time, we don't see carcinoid syndrome with bronchial carcinoid or with pulmonary carcinoid. But of course, it can happen, especially if the tumor is very large, more than 5 centimeters, or if they have liver metastases. I want to talk a little bit about pulmonary function test. This is the test we like to do when we are faced with a patient who has respiratory symptoms, dyspnea, shortness of breath, wheezing. And the reason we do this test is to see what the level of their obstruction is, and also to know what their lung function is. Luckily, most carcinoid patients are young, they're non-smokers, so they tolerate lung surgery very well. So most of those patients would have completely normal lung function tests, and that would make surgery, would make most of those patients good surgical candidates, because most of us would tolerate losing 50% of our lung function. But if patients are smokers, they have COPD or emphysema, then it's very unlikely that they would tolerate any lung resection. So looking into the lung function in advance would give us an idea about what options we have before considering treatment. And this is just an example about airway obstruction that we can see prior to surgery. So those are just a list of the diagnostic procedures that we proceed with. Chest X-ray most of the time doesn't show us the carcinoid unless the carcinoid is peripheral, because X-rays are not good for that. X-rays are not good for central airways. They are very good for peripheral parenchymal abnormalities. We typically don't use arterial scan in the diagnosis. At least pulmonologists don't use it. I know those. It's probably more relevant when we are trying to stage the disease, but probably the experts in the room can tell you more about that. Our role is more in the bronchoscopy and CT-guided biopsy. So if, in general, if the lesion is central, 75% of them are central, so bronchoscopy would be way more beneficial. If the lesion is peripheral, then going from the outside, doing a CT-guided biopsy would be a better way of reaching the diagnosis. So this is just an example of a CT where it's showing the lesion in the proximal airways. And multidimensional CT are also good in finding out the exact location of those central lesions. We rarely do this at this point because bronchoscopy would give us the best similar results and would be able to do the biopsy at the same time. So we tend not to do this multidimensional CT scans at this point. So that's a picture from a bronchoscopy. So with the bronchoscopy, we go inside the tube, look into the airways. So the normal airways would look just like this here, and you have an opening into the distal airway. This is abnormal growth that's complete, that is obstructing the orifice to the right upper lobe here, but air can still go in and out. So bronchial carcinoid have very typical appearance. It looks like a soft mass covered with intact bronchial epithelium. And some pulmonologists, we used to think in the past that just looking at this would give us the diagnosis. And mainly because biopsy has been associated with a lot of bleeding. So sometimes we can make the diagnosis without a biopsy, but that's not recommended, and a biopsy is still recommended at this point. As you can see, the tumor is quite vascular, so biopsy is associated with bleeding. In the past, we used to think bleeding is bleeding is we thought that bleeding can be life-threatening, catastrophic, but there are a lot of recent studies that showed that biopsy with a bronchoscopy is quite safe, and you can control the bleeding with just injecting epinephrine or just throwing some epinephrine on top of the tumor that would constrict the blood vessels, then you can do the biopsy safely. And the reason we don't like to just do cytology or brushing or just obtaining some cells from the surface, because the bronchial carcinoid is covered with this bronchial epithelium. So there are no tumor cells on the surface. We really have to penetrate into the tumor to get the actual cells. And the other thing is, with doing a biopsy versus brushing on the surface, we get more tissue, and then our pathologist can really give us a good determination whether this is typical carcinoid, whether this is atypical carcinoid, so it can be helpful in that regard. So we talked initially about the carcinoid syndrome that is very rare in the initial presentation. Because most of those tumors do not produce serotonin, the risk of predisposing, the risk of causing carcinoid syndrome with the biopsy is thought not to be very high. And in my practice, we don't typically give the octreotide, the medication to block carcinoid syndrome, before we do the biopsy. But it's very important to know about this complication. We have vials in the room. We don't break them unless patients need them. And that's very different from gastrointestinal carcinoid, where any maneuvering of the carcinoid tumor can cause carcinoid syndrome. And I don't know, Eric, if you have any comments about that, but typically, even when we're doing laser resection, I don't typically give the octreotide prophylactically. We tend to just be aware of this life-threatening complication, and we don't give it prophylactically because it's extremely rare. I have not had any carcinoid syndrome with any of the biopsy or laser resection of any of our bronchial carcinoids. As far as medical therapy, this is probably more for our oncologist colleague to talk about. So I want to, and Dr. Parker would elaborate more about that. Surgical resection obviously is the main treatment for this disease, and I don't want you to think that I'm telling you anything different at this point, but there are some cases that might be amenable to other topical local therapy. But at this point in 2016, surgical resection is the standard treatment, especially if it is atypical carcinoid and it's behaving more like closer to lung cancer. And the reason that topical treatments or local treatments don't work, let's say you have, let's say you have this endobronchial tumor here, and you try to go and do endobronchial treatment. By endobronchial treatment, we just go inside the airways and try to resect the part that we can see from the inside. But most of the carcinoids are not just intraluminal. They have a lot of extraluminal components, and that's called the iceberg phenomena. And that's the reason local or topical treatment or minimally invasive treatment don't work most of the time. And the other reason they don't work very well is because of the broad-based tumor. If you have a tumor that is like a polyp, it's much easier to resect from the inside. If you have a tumor with a very broad base, you could just see that it's very difficult to find where the margins are and to resect the whole tumor from within the bronchoscope. This tumor, on the other hand, has this stalk, or it has a polypoid appearance, and you could see the distal airways You could probably wrap a snare around it. You could do a laser resection in the bottom here and get most of the tumor out, if not all of it. So that probably would be a patient that would be considered for such treatment. So are there cases for bronchoscopic interventions? Maybe. And those patients need to have this obvious appearance where I could see all the tumor, we see the distal airways, we see the proximal airways, and we know that we're going to remove most of the tumor. And it needs to be central, then, because with bronchoscopy, we don't have access to the distal airways as much as to the proximal airways. And it also needs to have low rate of local and distant metastasis. So typically, typical carcinoid is the cases. Typical carcinoid would be the one case where we would think about bronchoscopic intervention as opposed to atypical. I just want to talk a little bit more about what's bronchoscopic laser. So when we do the endobronchial intervention, this is the local therapy for the tumor. Most of the time, we don't do it for cure. We do it for palliation. So there is a role at this point for bronchoscopic laser if a patient presents with complete collapse of their lungs. They are very dyspneic. Before we consider them for surgical resection, which would be for cure, we want them to feel better. We want their pneumonia to clear. So we offer them laser therapy as a form of palliation. So we go in with a bronchoscope with a laser. The laser would basically evaporate the tumor, would allow the patient to breathe better, would allow the patient to clear their pneumonia, that would clear all the mucus. Then eventually we would stage them again and see if they're good surgical candidates or not. And those are different tools that we can use to resect the tumors from inside the airway. And this kind of just show you what we start with here with an endobronchial tumor that completely blocks the right main bronchus, and with a combination of laser, balloon dilation, other tools, we can basically restore the airway flow. At this point, most of the case, or 99.9% of the cases I do for carcinoid are just palliative. So patients have complete obstruction, they are short of breath, they refuse surgery, or they're not good candidates for surgery. Those are the patients we do local therapy for. And that's another case where it shows good results here because the patient had this polypoid lesion that we were able to resect completely, and the patient had no evidence of residual disease there. So this local or topical therapy has been studied in the last 10 years. And there are, the first indication, as I told you initially, it's palliative. If patients have a lot of symptoms, we want them to open up their airways, we want them to feel better, we want them to clear their pneumonia, we go in and open up the airways and then stage them later. There is a role for endoscopic treatment before surgery. So if a patient presents with a big lesion that's completely obstructing the left main bronchus, that's the airway that just goes to the left lung, and we think that the patient might need a pneumonectomy, then we take another look, we say, what if we remove part of this tumor on the top, and then we can probably manage the carcinoid with just doing a lobectomy. And there are some cases where after doing endoscopic treatment, restaging, the surgeon was able to do lobectomy, which the impact of a lobectomy on lung function is way different than pneumonectomy. So endoscopic treatments might have a role in changing the eventual surgery that the patient would have and preserve lung function more than anything else. And this, I just want to share with you a couple of articles here that showed that in patients with typical carcinoid, that endoscopic intervention can be curative. And this is actually the largest study. It's from Netherlands, looked at 112 patients. So they took all comers, and what they did, they said, let's start with bronchoscopy with curative intent. So they took 112 patients, and in this study, in about 47 out of the 112, they were able to cure the carcinoid with just bronchoscopy and endoscopic intervention. Out of those 47, most of them were typical carcinoid, and only 5 of them were atypical carcinoid. The patients needed probably between 2 or 3 bronchoscopies. A lot of those patients who were not cured with bronchoscopy ended up having surgery. So what this study shows us that there is a promise in some patients who are the good, perfect candidates for endoscopic intervention. We can start with endoscopic intervention. And if they fail, those tumors are slow growing, so their surgery would still be an option. But we have to choose the right patient very carefully before we proceed with that. So my conclusion is that the use of bronchoscopic therapy has 3 roles. Palliative, that's just to open up the airways and let patients breathe better, clear their pneumonias, and then we can decide about restaging them, and then probably do curative surgical procedure later. Maybe it kind of allow for a more conservative surgical resection if we are contemplating doing a pneumonectomy, removing the whole lung. By doing some endoscopic treatments, we can preserve some lung function. And the third role might be for initial bronchoscopic therapy. That should be for very highly selected patients with central polypoid lesion, low grade or atypical bronchial neuroendocrine tumor. And that would conclude my talk. Thank you very much. Appreciate it.